Good afternoon. Welcome to everyone. It's great to have everybody together, unified by lack of pain, although a devotion to alleviating pain. We are here to award and honor Dr. Long with the 11th recipient of the Donald M. Long Pain Service Award, which will be given to James Campbell. I was told that I'm not introducing Jim and I shouldn't say anything about him, but I can't resist. So I just want to,
I'm sorry.
what?
I'm trying to get him to raise the sound.
I just turned it on.
Is anybody having trouble hearing? I hear an echo.
Twice.
Yeah, it's like unbelievably good. I was hoping for triple. So I just want to tell a quick story about Jim Campbell. Everybody here knows Jim and admires him and his his enormous gratitude for his enormous contributions that Raj will speak more about. But I just wanted to tell you a little bit about my own sort of recognition of what he did for me early in my career. When I came to Hopkins, I had done research at Harvard Medical School with some great people. And then I trained at Columbia and I came to Hopkins and I was so thrilled to be on the faculty when Dr. Long recruited me as an assistant professor. And I had a lab and I had, was starting, doing some work, but really my first year or two was really devoted to seeing if I could operate, seeing if all the skills I had learned as a resident, whether people would send patients to me and whether I could really build a practice. And I was so thrilled that very rapidly I did develop a very, substantial brain tumor practice. And I took good care of the patients and people were referring to me. And I felt really good about being on the faculty at Hopkins. And I had an office next to Jim Campbell's. I had a little cubby hole on the sort of like an appendage to Dr. Campbell's office. And one day he was standing outside my secretary's desk and my CV was on the secretary's desk. And he was looking at my CV and I was very proud. I had published in JX Med and Science and all these great journals when I was a medical student and, with the people I'd worked with. And so I liked when people looked at my CV because I was really, show off. I had really, all these special things that I had done. And Jim was just standing there outside my office looking through and I said, "What's up?" And he said, "Well, I'm just looking at this." And I said, "What do you think?" Because I was fishing for a nice compliment. And Jim looked at it and he said, "It's a tragedy." And I said, "It's a tragedy?" And I looked and I said, "Is that my CV?" And I said, nobody really ever described my record up to that point. I mean, maybe since then, but up to that point, it's a tragedy. I said, what's a tragedy? And he said, "This." And I said, "What?" And he said, "Look at what you've done. And you're just wasting your time here at Hopkins. All you do is," he said, "you could be at any community hospital doing what you do. You just, take care of patients and operate and stuff like that." He said, "But look at the potential that you had, working with Judah Folkman and doing all this research. And you're just practicing here. You should be doing so much more." And he really deeply rattled me. And we sat down together and he said, you need to get NIH funding. You need to get a grant. And I said, "Well, how do I go about doing that?" And he said, "Let me show you my CIDA." His clinician is, clinician, whatever it is, the CIDA, like a KOA today. And he showed me his grant that he was being funded by the NIH. And of course, it was a pain grant. It had nothing to do with any of the work that I was doing. But what he did is he said, "Why don't you take this and model just copy it, basically." He said, "CIDA, this is a successful grant, and just apply it to angiogenesis and the brain tumor research. But this is how you do it. You put a timeline, you put background, so on and so forth." And so that's what I did. And I modeled my first grant to the NIH, which was funded exactly on Jim Campbell's, except Jim's was on pain and mine was on brain tumor angiogenesis. The other thing is he said, and I said, "I'm too busy to do that." And Jim said, "You need to take a block of time off and stop doing clinical work and devote it to research and get this done." And he said, "Dr. Long will be okay with it. Dr. Long will be okay with whatever you do. If you do just clinical work, he'll be okay. Whatever you do, he'll be supportive, but you need to just take." And I said, "How can I do that?" And he said, I'll carry your beeper, I'll cover for you. And he said, but you need to go and lock yourself away and do that. And that graciousness and that brutal honesty that Jim is very well known for changed the trajectory of it did totally turn me in a different direction, because I did take 6 weeks off. In fact, I signed out to Ben Carson because he and I were both working on tumors together. And I just did nothing but research and got my first grant and many after that. But I really owe that to Jim sort of redirecting me in a very brilliant way. And he's done that for so many other people. So I think you all know he's professor emeritus in our department. He's director of the Plastine Endowment for Pain Research and Education. He's kept it going all these years. And he's, we'll come to how it's organized, but that's been Jim year after year, day after day, making sure that it runs according to its mission. And of course, he's president and chief scientific officer of Centrexion Therapeutics Corporation and many other companies that he's worked with and really helped nourish and develop. In a very, 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 I think Dr. Long would be incredibly proud that he's being honored with the Don Long Pain Service Award. And I believe Jim was the first faculty member that Dr. Long recruited to the faculty. He certainly was his protege. He certainly was, Dr. Long took enormous pride in Jim's accomplishments, both scientifically and clinically. The Blastine Pain Research and Education Endowment came really initiated from Blastine, who saw Dr. Long, saw Jim Campbell, and they solved this pain problem. And he was so grateful that he wanted to help other people and set up this endowment with this mission, but really set it up in such a way, in a visionary way, to support pain research and promote people devoting their careers to pain. What it does these days is, education, pain rounds. It's been going on for 27 years. Research, foster early faculty development, funding promising research, basic and clinical, and advocacy for pain research and pain treatment for patients. The Donlin M. Long Award honors those who've served the Johns Hopkins community in advancing the standards of pain care and embodied the institution's dedication to alleviate suffering and pain associated with the illness. These are it's a who's who of in our pain field. The previous awardees, of course, Dr. Long himself, when the award was named, he was the first recipient. And then, you can see here just some of the great people that we've had at this institution that have been recognized in this manner. We'll say something about, and it's both Dr. Long and Dr. Campbell, the board of directors of the Blastine Pain Institute or, fund really represents certainly Dr. Long's philosophy of not working in a silo. And I think it was set up in the way it was established was, I've highlighted there, it's the chairman of the neurosurgery department, the rehab, orthopedics, anesthesia, neurology, psychiatry, and oncology and palliative medicine, all by their position as chairs of those departments are on the Blastine board. And therefore help direct and make sure it's not just one, it's not narrow. It's that we're all working together and crossing disciplines to advance the cause. And there's also a incredibly high-powered advisory board that Matthias is now the chair of. Raj was the previous chair, and Jim helps lead and guide constantly. And you can see the other members here of it. So I'd like to turn things over to Raj, who's, as you all know, is an outstanding pain clinician, a researcher. He's professor of anesthesia and neurology. He heads the pain research for Hopkins and was the former chairman and current member of the scientific advisory board of the Blastine Pain.
Yeah. Good evening, I'm Srinivasa Raja, and it's my great honor and pleasure to introduce to you this year's recipient of the Donlin Long Pain Leadership. Thank you. Award, Dr. James Campbell, Professor Emeritus, Department of Neurosurgery, and the co-founder and chief scientific officer of Centrexion Therapeutics. It's a rare and special occasion when a mentee gets to introduce his mentor for an award. When I joined Johns Hopkins, slides are not advancing, in 1981, I was fortunate to be accepted in the lab of Jim Campbell and Dick Meyer, who served as my mentors. We, along with Matthias Ringkamp and many others, worked together for over 2 decades. The middle picture shows the laser thermal stimulator, fondly known as the Yellow Submarine, that was built by Dick Meyer, that was used in numerous studies in primates and our patients. Dr. Campbell grew up in Royal Oak, Michigan, received his bachelor's with high honors and distinction from the University of Michigan, his MD degree from Yale University. Dr. Campbell was one of Dr. Long's first recruits for the neurosurgical residency in 1974. He received his postdoctoral training with Dr. Robert Lamont and joined the neurosurgical faculty at Hopkins in 1979. Under Dr. Long's chairmanship, he served as the vice chair and the director of the residency training program for neurosurgery. As Dr. Braham already mentioned, he served as the director of the Blaustein Endowment for Pain Research and Education since its inception in 1988. As the Don Long Award was initiated by him and the recipients were chosen by the Blaustein committee that he headed, Jim declined to be considered for this award in previous years, citing a potential conflict of interest. It was finally a nomination letter by Dr. Long himself that convinced Jim to accept this award. In his letter, Dr. Long stated, "In my opinion, he and his collaborators were the pioneers in the elucidation of the neurophysiology of pain, and those early papers are classics of the field." Dr. Long concluded his letter by stating that I think it is now most appropriate that the enormous contributions of Dr. James Campbell to the advancements in understanding and treating seriously disabling human pain be recognized by awarding the Long Prize to him. The Blaustein committee was unanimously in agreement with Dr. Long's recommendations. Dr. Campbell is one of those unique individuals who excelled in clinical care, research, education, mentoring, and leadership roles in this institution and major national and international pain organizations. In his highly successful academic career, Dr. Campbell has published 125 peer-reviewed scientific studies in prestigious journals that have been cited over 29,000 times, and has written 60 editorials, book chapters, and reviews. He was a sought-after educator, and between the years 1981 to 2026, in the quarter of a century, he had over 220 presentations at regional, national, and international meetings. He has edited textbooks and reviewed and served in the editorial board of most of the major journals in the pain field. Notable among his leadership roles was that in 1996, when he served as the president of the American Pain Society, when he coined the phrase, "pain, the fifth vital sign." The next year, he also founded the American Pain Foundation, for which he served as the chair for a decade. Jim has co-founded several companies in biotechnology and drug development in the areas of immunotherapeutics, chronic pain, and other neurological diseases. He has been the recipient of numerous awards over the years for his research and his public service. And just to mention a few, the Jacob Javits Neuroscience Award from the NIH, the Grass Award from the Society of Neurological Surgery, the Kerr Award from the American Pain Society, the John Libeskind Award from the American Academy of Pain Medicine. And recently, in 2021, he was the John Lozer Lecturer at the American Association of Neurological Surgeons. Outside of Johns Hopkins, Jim is also an accomplished sportsman, having climbed the Swiss Alps, won a squash doubles championship, and then 20 years later, a father-son national squash championship with Colin, and an Elk Ridge Club golf tournament recently. Among the many ways he kept himself in shape was by kayaking across the harbor to and from work. Jim and his wife of 40 plus years, Regina, during his early years at Hopkins, Regina, one of Baltimore's best dermatologists, and Jim are the proud parents of two Yaleys, Ashley, a Hopkins undergraduate in medicine and presently a faculty in Wilmer Institute, and Colin, the exception to the family of physicians who received his MBA from Wharton and presently works for Datadog. The Campbell family believe in mixing pleasure with pain with the multiple several-day cycling trips in Europe and North America. Seen in the top left are three Campbells trying to fix a bike chain, and the family joke is, in the Campbell family, is how many years does it take to fix a bike chain? And the answer, I'm told, is 3 and a new chain. The Campbell family have also mastered the art of balancing their busy work schedules with challenging outdoor activities, such as running a marathon. In the middle panel is shown Jim and Regina trying to cross a grade 3 rapid at Montana. And when their first attempt was not graceful, they went back the next day and completed it successfully. I guess the Campbell motto is, if at first you don't succeed, try again. To help relieve the stress from work and these activities, Jim pursues his passion for the piano along with his daughter, Ashley. Please join me in giving a warm welcome to the Campbell family, most of whom are here today, and this year's Donlin Long Award recipient, Dr. James Campbell, who's particularly proud that he is able to fit into his wearing kilts of 42 years later without any change or alterations. Welcome, Jim.
I think you've heard the best parts so far. Thank you, Raj, for that very generous introduction, and thank you, Henry, are you still here, for those hyperbolic remarks. I really admired your work, and I don't know about tragedy, but
This the right one?
yes, that's good. So 3 of the core values that I've had in my career, I put on the title of this talk, has to do with listening, learning, and innovating. And I think about those values quite a lot. And if you're interested in the field of pain, the listening part comes in really handy. Let's see, to advance J. Here we go. It's a particular honor for me to receive this award that's named after my leading mentor in going into neurosurgery, Don Long. You've heard a little bit about that. It's a little difficult actually for me to believe that it's now 50 years since I first met Don Long. It's so wonderful to have Harriet, Don's wife, with us, and children, Elizabeth, and Lee and Kim with us. I think David wanted to be here. We're going to see him a little later, but David as well. I have remarkably been able to get my kids to be here, and you've heard a little bit about them. You see Ashley here and Colin over here with their spouses, Pete Creighton, who is a surgeon in the ENT department, Whitney Suffless and Colin, my son, you've heard, are not in medicine. They're not on the faculty here at Hopkins, but I am very proud to say that they are gainfully employed. Ashley didn't, Regina really didn't have time in her schedule, but she, I insisted that she take the afternoon away, and so we somehow fit into her schedule, and I'm so proud to see my Regina here. I have so many acknowledgements to make when I think about this award. I do not think about this award for myself personally, but actually for all the many people that I've had the privilege to work with. You've already seen this picture, and up in the right corner of this picture is Tim Hartke, and Tim was the glue that held our lab together. He was our chief technician, and it's quite remarkable that when Tim retired, that our lab came together from across the country. And these are people who hadn't been in the lab for years and years. And there was an amazing confluence of people that came to celebrate Tim's retirement. I don't think that happens very often. And it is really moving to see how that came together and to have our laboratory together to commemorate Tim. And I have to get one more dig in to score points with my dear Regina, but everybody knows she's the anchor for everything that we share in our adventure together. I was going to say a little bit about an early experience, and I think Henry alluded to this, but this was a patient of considerable means that was in the hospital under Don Long, and people who saw Don in practice know that he would do everything he could to help patients, and this particularly applied to patients who had chronic pain problems. And this patient with considerable means had a almost exotic presentation with pain involving both arms, both hands. His hands were predominantly kept in a fisted position. And I think out of desperation almost, Don asked me to come by and see this patient. He was actually hospitalized with this condition. He had seen neurologists, rheumatologists, hand specialists, rehab doctors, and it just wasn't getting anywhere. And I think one thing that put off the care perhaps was that he had such an elaborate pain problem. But to me, that was in keeping with many of the other things I was learning from the laboratory about pain and this phenomenon, which I'll talk about in a minute, called central sensitization. We went ahead and did a pretty simple operation. It was an ulnar nerve transposition operation, and his pain problem was corrected. And then we did the other side, and we waited and waited. His pain didn't come back, and he was essentially cured of his pain condition. And he generously wrote a check, and that became the Blaustein Fund or Endowment for Research and Education. And it's really great thinking back on that and what the lessons were. And the lessons really come back to listening being open-minded, believing the patient, and considering if there might be an underlying cause that can be addressed. I think back on the occasion of this to why did I ever get in the pain world? I fortunately have not had a pain problem that motivated me, as happens with many people, either the person or the family. Back in the 1970s, when I was at Yale, however, there were some really fascinating things. I knew that I wanted to be a surgeon, and I was deeply interested in neuroscience, and I wasn't sure how to put these together. The Cultural Revolution in China had come to an end, and there were reports from China that anesthesia was being done, that is, major operations were being done without general anesthesia, just using acupuncture. And there were reporters from the New York Times and others that went over and witnessed some of these operations, and this was actually reported to be the case, and that caught my attention, and I thought that was quite fascinating. I'm not sure that I actually believed it or bought it, but it was nevertheless quite fascinating. At around this time, Ron Melzak and Pat Wall, two leading scientists, published what has become known as the gate control theory. And the postulate was that the input from touch fibers could inhibit the input from the pain system. And this was, at the time, a revolutionary idea and led to the advent of doing spinal cord stimulation for pain. And that became a technology that just took off like brush fire. And this also occurred in the early 1970s. I approached Arthur Taub, who was head of neurosurgery research in Bill Collins' Department of Neurosurgery at Yale, about doing a project to look into the mechanisms of how stimulation of the nervous system could relieve pain. And this led to my first paper, which was published in the Archives of Neurology, examining this mechanism. Then the question is, where should I do neurosurgery training? And I became aware that Don Long had just taken over the Department of Neurosurgery at Hopkins. This was in 1973. And I met Dr. Long, and it was clear that this was the place that I needed to go to further my career with my interest in neurosurgery and my interest in pain. He was the only departmental chair that had a major interest in the pain field. And there were allusions to the idea that Vernon Mountcastle might figure into the equation somehow. That wasn't exactly clear. Vernon Mountcastle was one of the leading neuroscientists in the world. He had done monumental work, discovered the columnar organization of the neocortex, and had done leading studies in somesthesis, and really set the stage for the Hubel and Wiesel work that led to a Nobel Prize. And Vernon, around this time, had just won the Lasker Award, and the thesis was to do correlative psychophysics with doing recordings from the nervous system and try to put these two together to try to figure out how it was that sensations are signaled. He turned this work over to Bob, and that was very fortunate for me. Bob became my mentor, and Ron arranged for me to be able to intertwine a two-year fellowship in physiology with the training in clinical neurosurgery. There was a collusion of three other things. As we all know in science, sometimes it's not necessarily the scientific ideas that drive things forward, it's the technologies. And at that time, through work ongoing in Mountcastle laboratories, there was the capability of recording single C fibers. Those are the tiniest of the sensory fibers in the nervous system. And technically, recording from those was quite challenging at that time. There was also the belief by Mountcastle followers that everything really needed to be under rigorous control of a computer. And this was a pioneering time in terms of an in-lab computer. So we used a Link computer that had octal drives. The memory was 1 kilobyte, and one did octal coding with switches on the front panel. And this controlled the delivery of the stimuli and recorded a digitized version of the action potentials coming in from the electrophysiological recordings. And the third part of this was this laser stimulator. This is a picture of it. You've already seen this in Raj's presentation. And even as of today, this is state of the art in terms of delivering stepped temperature stimuli to tissues, to the skin. This is the landmark paper that Bob and I published. Bob was the mastermind, my mentor, and I was the slave during the electrophysiological recordings from early in the morning to late at night. It was an intensive time and very productive time because we were really the first ones to do quantitative recordings from the pain signaling system, and we were able to examine how the ratings of the pain stimuli correlated with the inputs of different classes of pain fibers. This is work from later on that Dick Meyer and I did, looking at a more direct correlation of the input of the nociceptive C fibers and the ratings of pain. And one can see it's a very tight correlation of effects. So overlapping curves indicating that the neural code for pain sensibility was likely the input from these classes of pain fibers. Now this is Dick Meyer, and on the right side of the panel, you see the laser thermal stimulator that he created. This was at the behest of Vernon Mountcastle, who believed that to study sensibility, that it had to start with an control of the stimulus, and that really was the impetus. But the way Mountcastle did things was to work with engineers at the applied physics lab. He had done this iteratively many times over time, and he did this with regard to approaching the engineers at the applied physics lab about building this laser thermal stimulator. And so I was one of the first ones to get a chance to work with this. And Dick, I don't know where you're sitting, but it did not work properly quite often. And we had to do, there were a lot of phone calls, a lot of visits to the lab. And then Dick started sitting in on some of our experiments. And he came once, and then he came a second time, and then this got to be a regular thing. And Dick and I started talking about what we were discovering physiologically, and it was an amazing pairing of complementary skill sets and interest. And Dick said, "This is what I want to do." And after I finished my residency and after I finished this fellowship, he and I went on to work together. We wrote our first grant when I was still a senior resident. There were no page limits, unfortunately, and that was unfortunate, not just for Dick and me, but especially for the reviewers. We literally wrote a book of about 10 to 15 years of work, and I can't imagine how the reviewers would even begin to approach this. But maybe they just fell asleep and got fatigued. But one day, coming out of the operating room, a person by the name of Missouri called me and he said, "Dr. Campbell, we want to fund your work." And at this time, I was just getting started with my chief residency, pretty busy, and we had no laboratory. And I called Dick and I said, "Dick, we're funded." And Dick said, "There's no lab. What are we going to do?" So we, right down the hall from Don Long's office, Harriet, I don't know if you probably were up there on Blaylock 14 many a time. And so right down the hall is where we established our laboratory. And we were off to the races. And once I finished residency and we really started doing our research work, it was one paper after another. I won't go into the details of this, but we discovered different classes of pain fibers. We discovered the phenomenon by which pain fibers become sensitized and became the neural basis for understanding the hyperalgesia or the hypersensitivity to pain that is associated with tissue injury. We looked at this also from the perspective of what happens with a nerve injury or what happens with painful diabetic neuropathy. What are the underlying mechanisms? What goes wrong and what goes right in the peripheral nervous system? This is an example of one of the experiments, and this is just the recording of a single fiber. And on the bottom row, you see the first trial, and then as you move up, you see successive trials. So this is just a repeated heat stimulus to the receptive field of the single A fiber nociceptors, a particular class of nociceptors. And you see nothing happening, but we kept repeating the stimuli, maybe just because it was easier just to repeat the stimuli than go find a fiber to record from that was responsive to heat. And I heard a little tick in the background. So I said, well, we should do this again. And we then iteratively recorded with successive stimuli. And then all of a sudden there emerged a robust response. And you can see as we go up to the top line, this amazing response. And this was sensitization of a nociceptor. And one of the first accounts of this, and this led to our first paper in Science, where we documented that it was the input of this class of fibers that accounted for the hyperalgesia, the abnormal pain sensibility that occurs with a burn to the glaber skin of the hand. Some people would say that being a physician and a scientist is a bit of a dinosaur. And I think for the surgeon, that's a quite legitimate question, because when one is doing experiments, one worries about the patients, one worries about what's going on in the OR the next day. And when one is in the operating room, one wonders about the research work, analyzing the data, writing grants, writing papers, and there seems never to be the right place to be. However, going bench to bedside has led to things in my career that just would not have happened had I been in one side of this equation or the other. I want to give 2 examples. This has to do with work with Dr. Raja or Raj, who you just met. And Raj joined our laboratory in 1981, so a few years ago. And he and I both saw patients who had a condition which we labeled sympathetically maintained pain. And this is under the umbrella of a broader set of conditions called complex regional pain syndrome. And the striking observation in these patients is that when you do a sympathetic ganglion block, some of you don't know what the sympathetic ganglion is. This is a separate part of the nervous system that has ordinarily nothing to do with sensation whatsoever. It just controls the size of blood vessels, sweating, and other functions of the peripheral nervous system. Again, not having to do with motor function or sensory function. Blocking this system, these sympathetic fibers in some of these patients leads to a very striking reduction in pain. Raj and I set about to understand what the neural basis of this is. And this involved several years of work and several papers to get this done, but we worked it out. And first thing we did was giving these patients propranolol, which is a beta adrenergic blocker. It blocks one of the receptors activated by the neurotransmitter norepinephrine. Nothing ever happened with propranolol. However, when we blocked the alpha adrenergic receptors, the other type of receptor activated by norepinephrine, there was a similar drop in pain as one would see with the sympathetic ganglion block. And this is shown, and this is just one snapshot of the work that we did. We see over time with the infusion was given intravenously to patients of phentolamine, this drug, this alpha adrenergic blocker. We see a drop in pain. It's quite precipitous once it takes hold. And there was improvement in the touch-provoked pain, which is sometimes called allodynia, and the spontaneous pain or the ongoing pain that the patient feels. Another experiment that resulted from this idea of being a scientist and a clinician at the same time was work that we did together. This was with Dick Meyer and Raj, where we were looking at the mechanisms for the different types of hyperalgesia that occur with an injury. And the black filled-in circles represent areas on the glaber skin of the hand where we applied a burn. And then we tested the sensory changes that occurred, not just at the area of the burn, but outside this area. The area within the burn is called primary hyperalgesia. The area outside the burn is called secondary hyperalgesia. And we tested both mechanical and heat stimuli. And the striking finding was that in the zone of secondary hyperalgesia, there was hypersensitivity only to the mechanical stimuli, not to the heat stimuli. In correlation with this, we were doing recordings from the afferent pain fibers in electrophysiological recordings and partnering the psychophysics with the electrophysiology. We established that the secondary hyperalgesia is due to a phenomenon that clinicians quite often cite with patients, and that's this phenomenon of central sensitization. And this is an elaboration of pain where the pain is described not just in the area of the injury, but in an expanded area. And there's great individual variability such that this very same lesion in one patient may be associated with no pain whatsoever. And anatomically, the same lesion in another patient leads to a very elaborate pain condition, which is where the allodynia occurs well outside the dermatomes. And so this whole body of work led to a further understanding of how abnormal pain sensibility occurs with tissue injury, but also nerve injury. Part of this work related to work we did with Susan McKinnon, who is a hand surgeon and did some of her fellowship work here in Baltimore, but then went on, she's actually then went on to become chair of plastic surgery at Washington University and a very prominent peripheral nerve surgeon. And with her contributions and some of the work that we did, we established that blocking the touch fibers eliminated the allodynia in patients with nerve injury. We did other experiments as well, but the upshot of this is that in nerve injury, this central sensitization arises from a nerve injury. And if one addresses the nerve injury, there is a capacity in many of these patients for the whole pain problem to get better. Dick Meyer and I wrote a paper that was published in a highly cited paper in Neuron a few years later that established a model by which to understand this. And this involves some complexities that I'm not going to get into, but this paper became a impactful paper in terms of establishing the models for understanding neuropathic pain. Now, I do see Michael Caterina here, and Michael is famous for doing work with David Julius and work that led to David Julius getting the Nobel Prize, and that was cloning the receptor for capsaicin. Now, we all have experienced capsaicin. It's the pungent ingredient in hot peppers. And we were using this at the time as a tool to study hyperalgesia because when you apply capsaicin to the skin, there's no injury. You come back and the skin is absolutely normal. And on the other hand, it causes ferocious pain, as we all know when we eat a jalapeno pepper. We noted, however, that when we did small intradermal injections of capsaicin, that when we came back a couple of days later, skin looked normal, touch was normal. But when we applied a heat probe, there was no response at all. There was no feeling of pain. And we then did this work quantitatively. This was work with Karen Davis, who now is an eminent researcher on her own at the University of Toronto. And she was a fellow with us. And Marco Papagallo, who is a fellow and a neurologist. And we did this study, which established this effect of one of the capsaicin analogs. This did lead to a product that is now used in the clinic, arguably underused. This is now FDA approved, and the idea here is that this is a high concentration of capsaicin that can be applied to patients for a short period of time, such as an hour, and there, in not all patients, but in a substantial number of patients, there is relief of their underlying pain. And this is approved by the FDA, for example, for treatment of painful diabetic neuropathy, a very common condition, actually. So you heard a little bit about this in Raj's introduction, but the reward for productivity is that you get asked to sit on editorial boards, you get asked to sit on committees, you get asked to do everything but the science that led you to that position. And that happened to me. And I came to be, at the time, the leading pain society was called the American Pain Society. And in 1996, I was president. And as part of that, I was to write a presidential address and deliver that at the meeting. So this was a Sunday. And the problem that we sat around and talked about was the fact that pain was widely dismissed as an important healthcare problem among physicians. And we were trying to figure out a way to get the message across that pain was important and that it should be assessed. And we felt that if pain wasn't assessed, there would be no chance of really doing any meaningful innovation, for example, to find new therapies. So in thinking about this one Sunday morning, I thought, well, we have vital signs, and vital signs are attended to by healthcare professionals. We have the pulse, the blood pressure, we have breathing, we have temperature. So why don't we just call pain the fifth vital sign? So that seemed like a good idea on a Sunday. I called up the executive director on a Monday, and I said, why don't we just create a button that says check the fifth vital sign? And they thought it was a great idea. And so this has led to some controversy, actually. I think it did ultimately raise awareness, and it did help to destigmatize pain complaints in patients. And I think it did lead to some stimulation of doing pain research. However, it was picked up by pharma companies as a commercial vehicle to brand the inappropriate use of opioids for certain pain conditions. And in a way, it very much backfired. But I think when one looks back at this with the benefit of hindsight, that it has led to an awareness, and that pain is more regularly assessed and measured in healthcare settings. So I'm hopeful that there will be a favorable legacy as time plays out. I became interested in where my career was going, and in the early 2000s, around the year of 2003, 2004, I started doing consulting for a leading life science venture capital company in California. And I had ideas about possible innovative products. I was very naive, really knew almost nothing about business and very little actually about drug development, but I did have ideas. And I started doing consulting with these extraordinarily bright people that happened to be able to write very substantial checks. And so in time, I left my full-time position at Hopkins and went into the venture world and became involved in taking operational role in different companies. In 2014, after hearing maybe 50 or 100 different no's from different investors, I was able to figure this out with two individuals that set us on a wonderful path of creating a new company dedicated to developing innovative therapies for pain. One was Saul Baer, who was the former CEO of Celgene. It's quite a story and quite a extraordinary outcome, and Saul did extraordinarily well on the behalf of his patients. And so just for himself as an investor, he introduced me to Jeff Kindler, who was the former CEO of Pfizer, and the three of us, with some venture capital money, were able to put together the company that I now work for, which is called Centrexion Therapeutics. I'm not going to say anything at all about what we're doing, but we have one of the largest pipelines of innovative therapies for pain. We've licensed one of these to one of the major pharmaceutical companies, and the other four are in development, extending from pre-IND all the way through phase 3. And we'll see where this goes. But as I approach my mid-career now, I'm very eager to see how this turns out. So I wanted a neutral party to evaluate my career. So I turned to ChatGPT as the arbiter of this. And I had no idea what would happen, but I put in the question to ChatGPT, who is James Campbell, and did he ever accomplish anything? And so I figured the answer would likely be, who is James Campbell? But ChatGPT did come back with an answer, and a very articulate answer that I ask you to indulge me by allowing me to read some of this, because I couldn't say this quite so well as ChatGPT. And I have arguments with ChatGPT, and I have found that it's often very much wrong. So I can't attest necessarily to the accuracy of this, but in any case, this is what was spat out when I asked this question. Yes, Campbell did make contributions. He was one of the first to emphasize the importance of addressing pain at its source. In the 1980s, he proposed that neuropathic pain should be recognized. In the early days, there was no such thing as neuropathic pain. It was, we had to start adopting a new language actually to even get started in the field. Dr. Campbell's research played a role in identifying how damaged nerves and certain receptors contribute to persisting pain, laid the foundation for developing treatments that target specific pathways involved in neuropathic pain, moving the field toward more targeted therapies. His work has influenced pain research and clinical practice by emphasizing the need to treat neuropathic pain based on its unique mechanisms rather than solely on symptom relief. So I'm going to stop there. I so much appreciate speaking before you, and the recognition is deeply felt, and thank you very much. There may be a reception in the back, I believe, Linda. So that's my understanding, is that there are soft drinks and little bites to eat in the back, and I invite you all to join at the reception. Thank you.